Multiple sclerosis, or MS, is a neurodegenerative autoimmune disease that affects the central nervous system. MS affects over 2 million people around the world, and symptoms include pain, tremors, slurred speech, fatigue, and more. The cause of MS is ultimately unknown. Most studies done on MS have been focused on mechanisms in the central nervous system that are associated with the loss of motor function. However, few have looked into the neurophysiological factors of pain caused by MS, including calcium calmodulin protein kinase 2A and interleukin 17. In our experiment, we focused on how calcium calmodulin protein kinase 2A, or CAMK2A, and interleukin 17, or IL-17, affect the amount of chronic pain in mice with multiple sclerosis. Our main finding was that CAMK2A activity in the spine of an experimental autoimmune encephalomyelitis mouse model was increased in comparison to a healthy mouse. Additionally, when we used techniques to inhibit CAMK2A, EAE symptoms were reduced, along with a reduction of thermal hypersensitivity, which is seen in EAE. In mice with a CAMK2A mutation, symptoms were reduced as well, with no evoked or spontaneous pain that is usually associated with EAE. We also discovered that IL-17, which is commonly associated with MS, is the cause of this hypersensitivity. All of these findings indicate that CAMK2A and IL-17 serve a crucial role in pain associated with multiple sclerosis. Multiple sclerosis is caused by an attack on the immune system that results in the degradation and destruction of neurons. The main effect MS has on neurons is demyelination, which is degradation of the myelin sheaths that coat the neurons in the central nervous system. Myelin allows for the process of information transferring from one neuron to the next to be sped up. Therefore, without myelin, signals to the brain are slowed down significantly and can sometimes be completely disrupted. Calcium calmodulin protein kinase 2A is vastly expressed in the central nervous system and is thought to be a factor in pain associated with MS. CAMK2A is also known to be involved in mechanisms in the brain, including long-term potentiation, which occurs in the hippocampus. In addition to CAMK2A, we also took a look at interleukin 17, since it is thought to turn on CAMK2A earlier in the neurobiological mechanism. IL-17 secretes helper T cells called Th17, which have been shown to have a role in MS pathology. Based on prior research, it is not known whether IL-17 itself also causes MS pain, or if it only turns on CAMK2A, which then initiates and maintains pain in MS patients. Female C57BL/6N mice were crossbred with CAMK2A mutant mice to form both mutant and wild-type mice. The experimental autoimmune encephalomyelitis model was used in mice to mimic symptoms of the human disease multiple sclerosis. EAE is the most commonly used model for MS because it similarly causes demyelination of neurons, which leads to motor dysfunction and pain. We gave the experiment group of mice EAE by injecting a myelin oligodendrocyte glycoprotein in combination with pertussis toxin. The control mice were only injected with the pertussis toxin. The health of each mouse was assessed using a clinical scoring system ranging from 0 to 5 for how paralyzed the mouse was. Additional motor activity and behavioral tests were performed on the mice, including a rotarod test, mechanical and thermal sensitivity tests, and a conditioned place preference test. Mice were also treated with KN93 and KN92 CAMK2A inhibitory drugs over the course of 8 days, as well as IL-17 antibodies and IL-17 proteins to test for direct pain induction. Experimental mice were also injected with CAMK2A siRNA while the control mice were given an RNA negative control substance. After treatment, tissue samples were taken and standard staining procedures were performed for each experimental group. All data was analyzed with ANOVA and post-hoc testing. Results were considered statistically significant at the 95% confidence level. Inducing EAE in the mice was successful with the presence of paralysis and increase in mechanical and thermal sensitivity, which mimics multiple sclerosis. Our first finding was that KN93 did in fact reduce motor dysfunction and mechanical and thermal hypersensitivity. Additionally, data showed that KN93 also decreased hypersensitivity that was already present in EAE mice. Treatment with CA-MK2A siRNA also reduced and reversed hypersensitivity. These findings help indicate the role of CA-MK2A in MS symptoms since both KN93 and siRNA are CA-MK2A inhibitors. It was also shown that EAE mice had higher levels of CA-MK2A in their spinal cord in comparison to wild-type mice. In addition to this, there were higher levels of CA-MK2A in the spinal dorsal horn of EAE mice. This is significant because this area is critical for pain mechanisms. Once again, these findings further signify the involvement of CA-MK2 in mediating EAE pain sensitivity. Looking at CA-MK2A mutant mice, they had lower paralysis scores than the wild type. They also showed resistance to motor dysfunction symptoms and no spontaneous pain that is commonly associated with EAE. The last experimental data we looked at involved interleukin-17. For IL-17 negative mice, EAE development was decreased. Additionally, EAE mice who were treated with an EAE antiserum had significantly less pain hypersensitivity. However, IL antiserum, when treated acutely, was not able to reverse already present hypersensitivity in the EAE mice. We were able to show that IL alone induced EAE symptoms because when treated with IL-17, mice showed decreased latencies and withdrawal to mechanical and thermal pain sensitivity. There is some possibility for error when performing these experiments and gathering this data. One source of error could be that any of the treatments could have affected each mouse differently. It is hard to guarantee that each mouse will respond the same way to every drug, which decreases the consistency and reliability of results. Another source of error could have come from how pain sensitivity was measured in each mouse. Every mouse could have a different level of tolerance for pain. Therefore, it would be hard to judge how EAE and the experimental treatment changed mechanical and thermal hypersensitivity. This would make comparisons between the experimental and control mice more difficult and less significant because of this possible difference in pain tolerance. The implications of this research are significant, given the very little that is known about MS pain neurophysiology. Identifying the roles that CA-MK2A and IL-17 play in the symptoms associated with MS is crucial for developing targeted treatment and therapy for MS patients. Overall, this research is very thorough and well organized. It provides all necessary testing to determine the role of these neurobiological factors in multiple sclerosis, and the use of EAE for the mouse model of MS was the right choice. However, there were some flaws in this research. In addition to the possible sources of error previously mentioned, the number of mice used for experimentation was never mentioned in this article. Because of this, it is impossible to tell if the sample sizes are big enough for the results to be statistically significant.